Good morning. My name is Dr. Kirk Hinckley. I am the Director of Education for Vapotherm. I am also the Chief Clinical Officer at a hospital in northeastern Pennsylvania. And today we'll be talking about work of breathing. I have a distinguished group of guests with me today, and I'll have them each introduce themselves before we get started with the questions. Dr. Jeremy Greenberg.
Hi, Kirk. My name is Jeremy Greenberg. I am an emergency and critical care physician at an academic medical center in southeastern Tennessee.
And Dr. Mark Gebhardt.
Good morning. I'm Mark Gebhardt. I'm an emergency medicine physician in Southwest Ohio, and also split my time doing academics as well.
And Dr. Ari Smet.
Good morning, Kirk. I am in the academic teaching community hospital, ICU pulmonary critical care, and a fellowship director here in South Florida.
Great. So thank you guys all for joining us today. We're going to talk a little bit about work of breathing and what that means to you. So let's get started. And I'll start with you, Dr. Greenberg. Recently, there was a paper that you authored in Frontiers of Medicine, and you hypothesized that clinicians should focus on reduced work of breathing earlier in critical illness. Would you talk about a little bit about how you came to this hypothesis?
Yeah, of course. It's kind of a funny, circuitous story or route. So I remember being a brand new intern in the emergency department, and I can't remember what she came in with, but I do remember the first time I saw this patient, something wasn't quite right. I presented it to the attending, and he immediately called in the cavalry. The patient was intubated, they were aligned, RT was in the room, multiple nurses were in the room, and I was kind of left scratching my head after the fact going, whoa, what did I miss? Because when I saw her, I could tell that something was a little off, but it wasn't obvious or apparent to me why. So I pulled the attending aside and I said, what did you see that I didn't? And the only response that I got was, she just looked sick. So this story kind of repeats itself a number of times as I'm a brand new learner. And each time I'm left going, oh, they were just sick, thinking it must have been because of the diagnosis that I had missed, or starting to worry as I'm going home at the end of my shift that there's some sort of sixth sense for identifying when somebody's going to get really, really sick that I apparently don't possess. Finally, it comes to a head. Our most brilliant attending, our program director, one day makes me admit this patient where I can't find anything wrong with them. Their labs were normal, their imaging was normal, and I'm feeling like a used car salesman trying to get the hospitalist to admit this patient. Lo and behold, this patient has a cardiac arrest later that night, and I'm finally going, all right, I've got to figure out what it is that I'm missing. So I stayed up all night long reviewing this patient's chart, and finally, the only thing that I found that was abnormal was that her documented respiratory rate was high. Not being able to come up with anything else, I start using this as a sort of litmus. Maybe this has something to do with what everybody is seeing. So I started paying attention to the respiratory rate. And then that led to, well, their respiratory rate's normal, but it just doesn't quite look normal the way that they're breathing. So fast forward a number of years and I'm in fellowship, it's day one, and I'm learning about the concepts of oxygen, of shock, and oxygen delivery relative to oxygen consumption. And this is mind-blowing to me that for the first time in my career, I'm being taught, well, shock isn't just a vital sign. It's not just a blood pressure, and it's not just a lab test or like an elevated lactate. It's actually this concept that boils down to what's happening at the cellular level. And what was so impactful about learning this was that it wasn't just all about shock being inadequate oxygen delivery. It wasn't about it being enough oxygen or hemoglobin or cardiac output. We really focused on what was going on the other side of the equation to balance things out. What was happening at the tissue oxygen consumption side? How much oxygen was being consumed by the cell? Now, something that was really mind-blowing to me at that time was being introduced to the concept of intubating, putting a patient on a ventilator because they were in really bad shock. Where I trained, we had, the moment we were adding that second or third vasopressor, or things weren't turning around with the initial blood product resuscitation for hemorrhagic shock, we would often move to intubation. And I was seeing that these patients that we had previously just been focused on shock and their hemodynamic resuscitation, we were putting them on ventilators and they were getting better. Now, it wasn't fixing everything, but the amount of hemodynamic rescue that we were having to do was getting less. Now, there'd be a little bit of initial drop in the blood pressure when you first put them on the ventilator as we transition from, spontaneous to positive pressure ventilation. And as you added those sedative infusions that were making them a little bit sleepy, but by and large, these patients were getting a little bit better. After a time, and after the initial shock and awe wore away, I kind of went, well, why are we waiting? Why are we waiting so long for them to end up on the ventilator? If we can do something, if offloading the work of breathing has such profound implications on that relationship of oxygen delivery relative to tissue oxygen consumption. So that kind of became, that was my origin story for how I became really, really fixated on what can we do to offload work of breathing.
Great, thank you. So Dr. Gebhardt, when I was in training, you were that attending for me. I was always impressed that you were able to pick out critical illness, really with a glance of your head. Can you tell me a little bit about what this work of breathing looks like to you, and if there's challenges in picking out that critically ill patient based on this?
Yeah, thanks, Dr. Hinckley. I guess you date us there, going back a bit. I've often done that with the residents over decades of teaching emergency medicine now, and sort of the idea of diagnosis at a glance, or sick or not sick, as somebody comes into the emergency department on the gurney. And I honestly have relied a great deal on my just initial look-see at a person. But I think that initial look-see that we all, as experienced clinicians, have is a pretty deep understanding of what's going on from a basic science level all the way behind in the picture, the human physiology and the derangements that are occurring based upon what we see with our eyes, and those easily discernible physical findings of perioral cyanosis or tachypnea, accessory muscle use, etc. So we sort of use all of those in a summative way to determine that this person has an increased work of breathing. And it dates clear back to my pre-hospital days as I looked at people who were short of breath. And let's say these are the most short of breath we would talk about here. And our options outside of the hospital were few. And during the first part of my career in emergency medicine, our in-hospital options, they were also relatively few. And I would watch these people intently, seeing how they breathe. And we basically arrived at a point fairly soon where we made a decision that they needed to go on a ventilator. And we moved quickly in that direction. Fast forward now to 2023. And as you look at somebody without work of breathing, still decades of experience, you pull together all of your understanding of basic science. And I recall just recently looking at our hemoglobin dissociation curve that we are all familiar with, and going over it with other students and starting to try to explain to them, when we see that patient in extremis who has that difficulty breathing, that you can no doubt determine is sick from just a visual look, you could then swing over and physiologically, through the clinical lab or through medical imaging, obtain testing that's summative that proves that point. So when I see that increased work of breathing, I, as a physician, am eager to find less invasive ways to more effectively and efficiently deal with it. So that's a summative sort of statement of 20 plus years in emergency medicine and recognizing sick versus non-sick and knowing that there's a great deal of physiology behind that we as physicians use to guide our patient forward.
And Dr. Cement, I think that's an important question for all of us to answer. So can you tell us a little bit about what you think this work of breathing looks like, and then we'll roll into how you use that as a marker to determine if it's time to intervene.
Yeah, so I think in the ICU setting where I'm mostly at, people could certainly recognize somebody who's immunosuppressed. Let's say they had chemotherapy from cancer, that they're more likely to have problems. Somebody who's been with a viral infection, let's say COVID, they're more likely to get a bacterial superinfection. But when it comes to the work of breathing, our residents don't look at that as a risk factor for complications, mostly because everybody has a respiratory rate of 12 to 20. No matter where you see it, it's always documented. Oh, that's 20, that's normal. We have to do a better job of recognizing work of breathing as a risk factor for downstream complications. So, and it's very clear to me over many years that it just sucks up the oxygen utilization and it leads to, adverse consequences. So getting it early is preventing the avalanche. So basically, once it starts, it just starts to pile up, and then you can't really control it. The key really is to hit it early and block the cascade. I like to describe it to the residents as an avalanche, that once it starts, it's really hard to stop. So you really got to start attacking this avalanche early on.
So I mentioned we're going to roll into the next question on this, and I'll stick with you, Dr. Cement. So how do you determine what increased work of breathing merits an intervention? And is there a threshold, a respiratory rate, or otherwise that you use?
Yeah, that's a great question. There actually is multiple ways. It's not just one. So I think we've talked before about respiratory rate, 20 to really 30, over 20. But even 20 itself could be respiratory distress. In fact, the SOFA, if you know the SOFA criteria, it's 22, the respiratory rate. They picked this arbitrary number, but looking at a patient actually is just as important than the actual number. So seeing somebody using their accessory muscles, even with a respiratory rate of 10, to me would be increased work of breathing. Obviously, looking at criteria, if you happen to have PCO2 on board, above 45, showing that the patient's already having difficulty ventilating off. A pH level of less than 7.33 would tell you that the patient is struggling keeping up, assuming that it's just primary respiratory issue. So values typically that we use in the ICU would be respiratory rate, PCO2, pH. However, bear in mind the accessory muscle to me is actually, like Dr. Greenberg said, the sixth vital sign. But to me, that's the key there, is how much muscle you're using to breathe.
So Dr. Greenberg, you wrote the paper, right? So what is the current standard of care in treating increased work of breathing, and what are you proposing we could change?
I don't think there is a standard of care when it comes to treating increased work of breathing. I think that we wait. We wait until there's overt failure, and then we act. We wait until the oxygen level makes us uncomfortable, and then we act. We wait until the pH is down and the CO2 is up, and then we act. We wait until there's overt failure. That is really our standard. And really what I think we need to do is we need to intervene early. And I try to make it really simple. If you notice somebody's work of breathing, if you notice somebody's breathing, that is abnormal. And we should work to do something to offload that. And I, in my mind, the most non-invasive, potent tool that we have to do that is with high flow devices, specifically high velocity therapy. if high work of breathing, I think the standard should be offload that high work of breathing regardless of the cause, regardless of it's a cause directly attributable to the lung, or if the high work of breathing is compensatory for shock or perishock state, or if the high work of breathing is compensatory for severe metabolic acidosis. If there's high work of breathing, offload the work of breathing with a high flow system, high velocity system.
So again, we'll stick with you to talk about a little bit about the clinical evidence to support the use of high velocity therapy for these increased work of breathing patients.
So there's 3 papers that that I really love. The first one is patterns of unexplained hospital death. And for anybody who works in the inpatient setting, this is a must read. What this healthcare system did is it looked back in time at all of their inpatients that unexpectedly died. And what they found was that regardless of the cause, didn't matter if it was sepsis, didn't matter if it was a pulmonary embolism, heart failure, or MI. What they found is that in every single one of these patients, the first thing that happened was the respiratory rate went up. And the respiratory rate went up long before the oxygen saturation dropped, long before there were metabolic derangements. Long before the CO2 went up or down, the respiratory rate went up. So in my mind, this is really the canary in the coal mine of impending badness. There's also this very, sort of rinky-dink tiny study that was done by a number of anesthesiologists. Actually, I think it was in New York, where they took patients who had non-pulmonary sepsis. So they had bad infections with life-threatening organ dysfunction, but it wasn't because it was an infection directly into the lungs. And they measured their work of breathing. They measured their work of breathing at the outset, just with regular oxygen, simple nasal cannula. Then what they did is they put them on a high flow device, and they found that in every single patient, their work of breathing went down. They then took off the high flow device, put them back on the original nasal cannula, and the work of breathing went right up to where it was. So now we know high work of breathing is the canary in the coal mine for badness. And we have this technology that can offload that work of breathing. Now, for me, the study that's really the game changer is the Doshi study, where they took patients presenting to the emergency department with undifferentiated respiratory distress. This was a multi-center, 5 centers that included academic, community, and they didn't have a definitive diagnosis. They randomized them to high velocity therapy versus non-invasive positive pressure ventilation. And they found that there was that we were achieving the same wonderful ends. There was it offloaded the need to intubate. It decreased the respiratory rate. It raised the pH. Everything looked better. In my mind, these are 3 studies that, when compared together, really provide a convincing case that as soon as we see high work of breathing, we should be doing something about it. And ideally, we should be doing it in the least invasive way possible.
Great, thank you. So Dr. Gebhardt, Dr. Cement, so Jeremy mentioned using high velocity therapy early in the course to address the work of breathing issues in these critically ill patients to kind of buy time and help treat the underlying condition. What are your thoughts on this approach, and how do you currently use high velocity therapy for increased work of breathing patients? So Dr. Cement, we'll start with you.
Yes, so for a variety of illnesses, I'll use the high velocity, therapy to really, like you said, to decrease the respiratory rate, to ensure the oxygen utilization is down. Do you want me to give specifics? Is that what you're asking for, a specific example or patient population?
So I think we'll move to specifics afterwards, and you can tell us about any types of sepsis or metabolic acidosis patients. But if you want to fit it in now, that'd be great.
But yeah, so essentially what it does is it does buy you time to help work up the diagnosis. A lot of times, even when they reach the ICU, we're still unsure about the diagnosis. So before they crash, it's a good time to buy time. You still need to buy time, and fluids and pressors can buy you time, but we often don't think about the respiratory apparatus as well. It's another mechanism to buy time to allow us to further our diagnostics. And then I guess we could go into the specifics after Dr. Gebhardt.
You know, Dr. Hinckley and everyone, I would just emphatically say absolutely early. And I'm sure you see this in critical care medicine, that if we, take steps and institute measures early on in the emergency department when that patient arrives, that 60, 90, 180 minutes that they're with us in the emergency department before they move to your intensive care unit is quite impactful. We take steps to obviously lessen morbidity and mortality of our patients. To our healthcare administrators on their side, we decrease the time our patients spend in your intensive care units, and overall their entire hospital time. So when we're able to deploy high velocity therapy through a nasal cannula to avoid endotracheal intubation and a several day stay in an ICU on a ventilator with complications that may ensue, that's why I say absolutely early. And I think, it's just vitally important, and I explain this to medical students and residents and emergency medicine attendings, that we extract information from a number of different areas and we intervene so early in emergency medicine. And so when we see that patient with that increased work of breathing, and by the way, Dr. Hinckley, I kind of divide that work of breathing into like two sort of categories: the subjective assessment and the objective side. And on my subjective side, it's fatigue, family, and friends. And they know about that patient. And they're like, that's my dad. Last time he looked like that, an hour later, he was intubated. So then there I come and I jump in and intervene immediately with the high velocity therapy. And then that hour later, dad is not on a ventilator. Dad has nasal prongs in place and is speaking to the family. So absolutely early, because it goes back to some of the science I talk about when we look at that dissociation curve. And the longer we let physiologic derangement go, the worse it gets for our critical care colleagues to have to clean up in the ICU.
I would just like to add to that, Dr. Gebhardt, just to put in numbers, because we like numbers too. So, the famous Kumar study in infectious disease ICU is that for every hour that we delay the appropriate antibiotics, we're increasing mortality by 8%. They're probably,
yes.
We don't have a number yet for the work of breathing, but I bet you that for every hour of increased work of breathing, we're going to see a 5% or 4% increase risk of mortality. So early on, the better, just like you say.
So I get questions all the time. People say, well, can you use high velocity therapy for this? Can you use it for that? Of course, COVID made it, high velocity therapy is a COVID device, or it's just for lung stuff, if you will. Do you doctors, and I'll ask all three of you, do you use high velocity therapy on critically ill patients that are not primary lung issues? Are other things that are causing critical illness that have increased work of breathing? Are you using the high velocity therapy device that really has an indication for patients with respiratory distress that are spontaneously breathing? So Dr. Greenberg?
Yeah, absolutely. High work of breathing can accompany and does accompany so many pathologies. It accompanies pathologies that live in the lungs. It accompanies pathologies that are nowhere near the lungs. And so I really see high velocity therapy as my go-to tool, regardless of the cause, for anybody who's got high work of breathing. If high work of breathing, I'm going to put them on that, because it takes time. It takes time to figure out why they're working hard to breathe. And this is, in my mind, the least invasive device that buys me more time in order to address the underlying cause, to fix the why.
And Jeremy, maybe you can give us an example of some of these types of patients, be it sepsis patients, I don't know, trauma, metabolic acidosis. Are there any types of patients that you could tell us specifically about?
Yeah, like a specific case.
Sure.
Yeah, actually just last week, I got called down to the emergency department. It was this 45-year-old guy. He had severe obesity. His BMI was 60 plus. And he had sleep disordered breathing. He had heart failure, hypertension, diabetes, whole metabolic syndrome derangement. And he had come into the emergency department he just wasn't feeling right. And his respiratory rate was high. His work of breathing was high. So he came in at that, that unfortunate time of shift change. So the first team of doctors saw him and said, this must be sepsis. So they did the fluids and the antibiotics and kind of went down that route. And the next doctors came in and said, what are you doing? He's got heart failure. So instead they gave him diuretics. And then anytime you see that fluids plus diuretics, they're probably going to end up in the ICU at some point. So I get called and I go down there, and I'll be honest, I didn't know, was this heart failure? Was this sepsis? It was a little bit of both. But what was going on definitively was that he had really high work of breathing. And so we put him on high velocity therapy. And what was fascinating about this case is that his heart rate came down a little bit. His lactate came down a little bit. And he looked just a little bit better. Now, he ended up having severe sepsis and ultimately progressed to septic shock because he had a necrotizing fasciitis of his perineum, or Fournier's gangrene. And it wasn't that the high velocity therapy fixed everything, right? That high velocity therapy didn't have anything to do with the infection that he ultimately required antibiotics and surgery for. But it bought us time. It made him better. And what continues to just blow my mind about cases like this is that these things are getting better despite the fact that we're not doing the traditional things that we think bring lactates down or bring blood pressure up. So this was, in my mind, a great case of we offloaded the work of breathing. It bought us time. Things got better. Had nothing to do with the lungs.
Dr. Samet, could you give us some examples of non-lung related pathology that you might treat work of breathing?
Yeah, so we have a rash of GI bleeding cases in the ICU. So typically, if a hemoglobin is about 6 or 8, that's not so terrible. You just transfuse up. But we're seeing a lot of hemoglobins less than 4, 3, and their oxygen saturation, these patients could be completely normal. So what I try to teach the residents and fellows is that don't hyper-focus just on the oxygen saturation, remembering that oxygen delivery is cardiac output times arterial oxygen concentration, and that arterial oxygen concentration, remember, is hemoglobin times your saturation, but then there's plus this PO2 times a 0.002, which most of the time the PO2 doesn't matter. However, when the hemoglobin is less than 4, that PO2 actually does make a difference. So even if your oxygen saturation is perfect, getting the PO2 higher in certain cases actually offloads that dissociation between the oxygen utilization and oxygen delivery, preventing lactic acidosis, but more importantly, preventing the further cascade of events that can happen. So I would say that anemia is an underutilized area for high velocity. It decreases the work of breathing.
Yeah. In emergency medicine, a very common type of cardiac arrhythmia that we see is atrial fibrillation with rapid ventricular response. And in my patient population, I think I see one of those people every shift. And I do notice that in many cases, and these are people, have a heart rate which is irregularly irregular and between 150 and 200 beats per minute, that many of them are quite tachypnic when they come in. And so recently, over the past 60 days or so, I've been applying high velocity oxygen delivery while we are treating their cardiac arrhythmia. So as you approach the patient with your armamentarium of antiarrhythmics, adjunctively deploy high velocity oxygen at the same time, because the patient's sitting there in the bed in front of you, breathing 20 to 30 breaths per minute. You're understanding that contributes to physiologic derangement. So what I have found is resolution of the tachydysrhythmia when you deploy the high velocity therapy is so much quicker. And the antiarrhythmics typically work fairly quickly, but you're able to subjectively, get the family to sit there at the bedside and feel, my gosh, this is so much quicker. My family member is taken care of so much more quickly. So it's now another tool of mine as I approach a primary cardiac dysrhythmia, not necessarily a respiratory case where I've amassed a lot of experience with COPD and CHF. And as we've gone through the COVID pandemic in those areas, but starting to branch out. One area for the group that I don't have experience using this for is in trauma. But from a basic science understanding, I think, I would certainly want to consider use of that in my trauma patients. That was an area, Dr. Hinckley, that I just don't have experience.
Can I add one, Dr. Gebhardt, to that list also that I see a lot, obviously pulmonary critical care, is post-extubation. Post-extubation studies have shown, we already have the 2016 Hernandez JAMA, you could look that study up with high flow therapy, but essentially even those patients that you think are gonna fly and extubate fine, there's about a 15% chance of reintubation. If you put a high flow therapy, your chances of reintubation go down to 5%. I typically use, my patients get extubated either to high flow or BiPAP, but they definitely get extubated to some form of flow therapy.
And has anybody had any experience in treating the trauma or polytrauma patient with high velocity? Dr. Greenberg, is that something that you have experience with?
It's been a while since I've been in the trenches resuscitating a polytrauma patient. I would imagine, one of the factors that I do want to mention is that we're not just focusing on the oxygen saturation and administering the therapy. Really what it sounds like we're all looking for is that lowering of the respiratory rate. And I would think whether it's trauma, whether it's infection, whether it's arrhythmia or bleeding, if you can slow that respiratory rate, if you can begin to relax that sympathetic dominant response, begin to engage that parasympathetic response, that rest, digest, and repair response just by offloading the work of breathing, how would things not get better?
Yeah, I think about it the same way, and regardless if this is a trauma patient, a hemorrhagic shock patient, a metabolic acidosis patient like DKA, for example, and really focusing on that tissue oxygen consumption and shunting of that cardiac output back to whatever ails them. It really doesn't matter what category they fall into. But the high velocity therapy is treating that respiratory distress, that increased work of breathing, and the resulting tissue oxygen consumption that's eaten up by the respiratory effort. And so, that's kind of how I've thought about this, especially of late. So anybody with any type of experience in treating metabolic patients, DKA, AKA, anything along those lines?
Yeah, absolutely. Patients with severe DKA, it can be difficult for them to maintain a minute ventilation that sometimes needs to be 3, 4, even 5 times normal in order to compensate for the severe metabolic acidosis. And these are patients that we know we ideally don't want to put on mechanical ventilation because that's a minute ventilation. This is very difficult to match with a ventilator and to do so in a safe and protective way. And so even though these patients almost never have any oxygen derangements, putting them on a high flow, even if it's at room air, can profoundly offload the work of breathing necessary to compensate for that low pH. So DKA is one of my favorite indications to use high velocity therapy.
Well, you all are here probably because you're aggressive users of high velocity therapy. What can you tell me about how your colleagues in your institutions use the therapy and how aggressive they might get. Are they doing anything novel? Are they treating these increased work of breathing patients like you gentlemen are? And we'll start with Dr. Gebhardt.
You know, three groups of people: medicine, nursing, respiratory therapists, that come to mind when I think about that. Most of my colleagues in medicine will, it sort of depends on where they're at in their practice, how long they've been doing this, because I think you've got the group that slides to intubation. You've got a big group that loves to use NIPPV. And then you've got, I guess, the younger physician or the physician who takes the opportunity to gain more knowledge would jump to high velocity therapy. Respiratory therapists raise an eyebrow to me when I have the patient in AFib with RVR and I'm calling them to my department to put the patient on high velocity therapy. And it takes a moment. And a lot of times I'll have my graph of the different pieces of evidence that are out there and pictorial representations, because I have to quickly bring them up to speed and say, hey, pH, work of breathing, this is why we're going to do this. So sort of that group. So I spend a lot of time with my respiratory colleagues trying to bring them up to speed from a knowledge standpoint as to why we're going to deploy this. And then my third group is my nurses, who largely wonder why I'm doing it as well. So in that nursing world, I have to also bring them up to speed and understand. So it causes me to have that question, obviously, for the medical student and the resident now, be it an emergency medicine or a critical care fellow, or a surgical fellow in a trauma program, they're probably receiving the information. But Dr. Hinckley and others, it makes me just wonder about in these other educational programs and nursing programs or respiratory therapists, are they even getting this? And I say that because I have brand new respiratory therapists that don't seem to understand what I'm doing or why I'm doing it.
And Dr. Samet.
So yeah, we have a complete buy-in with high velocity therapy from most departments, because we had the onset of the machines when COVID hit, and clearly Vapotherm or high velocity units saved lives. It was so evident to everybody, so everybody sort of fell in love with it. I still think one subgroup population where it typically BiPAP still reigns supreme over high velocity is still the COPD or hypercapnic patient. There's still a resistance, I think, in respiratory care to at least try high velocity therapy in that patient population. But overall, in my institution, it was so evident that high velocity saves so many lives that there's a complete buy-in.
And Dr. Greenberg, what's going on in your facility?
Emergency physicians tend to be early adopters. They see something work and they're like, yeah, I'm all in. So at my hospital, we're very fortunate that the emergency department is exceedingly aggressive in its use of high velocity therapy. And that's had this wonderful indication creep that's crept into all of the ICUs. And I'm seeing it slowly, but more and more for all sorts of things. Patients getting extubated directly to it, and the respiratory therapists recommending it because they've seen cases where, oh, it was a borderline extubation call, we should do it, or gosh, we're just not that great at predicting who's going to do well once we extubate them, so why not put them all? And so it's slowly started to creep into all of these different reasons, but I really have to credit our emergency department for being the early adopters. I think there was some hesitation from some of my colleagues thinking, yeah, it's a good in the ICU, I should say, that it's a good device for getting some oxygen to patients who are hypoxemic, but I just don't know about the other things. And I think the COVID pandemic really squashed that. I mean, we would have just swaths of patients all over the hospital sitting on high velocity therapy for days. And it really, really saved a lot of lives. And I think that things will never be the same since then. It was impossible not to see how profoundly impactful it was in that population. And I think since then, we're just seeing ever increasing usage of it.
So we've had this conversation all over the country, and we talked to physicians, nurses, respiratory therapists, and one of the things that we get is, especially from respiratory therapies, yeah, we treat these patients with increased work of breathing. We're addressing them. And I think if you watch Game Day and Lee Corso, the physicians say not so fast, right? They say, do we really? Like, is it really enough that we do the old ER mantra, right? If you're going to ABEM General, you're doing IV-O2 monitor, right? That's what you do with all our sick patients. And is that O2, is that simple nasal oxygen or face mask oxygen, is that really addressing work of breathing issues? And I think physicians would agree we are not. So while the respiratory therapists are kind of disagreeing and say, yeah, we're addressing this. What are your thoughts kind of on this dynamic? Are our therapists aggressive in picking out these critically ill patients? Are our colleagues or ourselves, are we aggressive in doing more for these ABEM general type patients that come in really sick? Are we doing more than just simple nasal cannula or face mask oxygen to help with their work of breathing? And we'll start with the ER doc. So Dr. Gebhardt.
You know, it kind of goes back to my comments about the understanding and approach of the respiratory therapist when it comes to the work of breathing these patients. And we all, in our different institutions, have seen the workforce affected and impacted, most likely adversely over the past 2 to 3 years. And so I have a large number of respiratory therapists that I would say are under 2 years of experience now. Spread fairly thin across a busy medical center. So I think, Kirk, as you said, we jump to the ABEM general approach, IV-O2 monitor, and someone puts a cannula or a mask on someone simply to look at the pulse ox number. And they're like, it's going up, we're all good. But we all know there's a lot more to it than that. So I think as we look at how high velocity therapy is incorporated into our medical practice, I think it's, you know, imperative that we spend a significant amount of time with our respiratory therapists in our institutions. And where I work, I have good buy-in from pulmonary critical care. So, you know, we're starting that. And I think as things normalize, as we have all emerged from COVID or are emerging, hopefully what I see is we get back to an opportunity to teach people again, to get them to understand that, you know, a pulse oximeter on your finger and a probe and some supplemental oxygen, it isn't always enough, because you've all seen it. You walk away from that patient, you go past their room, 10 minutes later, still tachypnic, even though they're on 2 or 3 or 4 liters by cannula, or maybe somebody puts them on a non-rebreather mask. So I think we have to make a more targeted and very specific effort to educate the respiratory therapist, because if they're at the bedside before I'm at the bedside because the nurse called them, I need them to be thinking forward and ahead so that we address work of breathing.
And Dr. Greenberg?
You know, I still see the cavalry get called in, you know, RT at the bedside, 2 nurses sticking for IVs and labs, the physician standing at the head of the bed or the entrance to the room. But it's usually only done when there's overt failure of gas exchange. It's when something is failing and the patient is approaching death. And so hypoxemia, severe respiratory acidosis, or severe hypercapnic failure, this is when I see the intervention. And I think that what we're missing is that we could have intervened a lot sooner. So to answer your question directly, no, I don't think that anybody's really doing enough to talk about, to think about, and to intervene with this high work of breathing. And just as point of care ultrasound has become synonymous with the initial resuscitation for a sick patient, I can't fathom taking care of critical illness without having point of care ultrasound anymore. It gives me so many answers about so many things. I really think high velocity therapy needs to be that go-to device anytime there's remote suspicion of illness, it really needs to be part of that ABC IV O2 monitor. And I think it should replace those devices that supply oxygen, but don't offload the work of breathing. It should supplant the simple nasal cannula or the non-rebreather. It needs to be part of our initial resuscitation for any and all potentially or overtly ill, critically ill patients.
And Dr. Smith?
The only thing I would add to that, and like you said, is the hyperfixation on oxygen saturation. If you take two patients exactly the same at an RRT, and one is breathing, they're both breathing at 20 times a minute, but one has a saturation of 89%, one has a saturation of 98%, you're 10 times more likely to hear the respiratory therapist say that the one in 89% is having respiratory distress. So like you said, we just have to hone in our senses to really recognize what work of breathing really means.
Yeah, and I think from personal experience, so I used to fly in the Air Force, and I did what was called critical care transport. And our team was small, so I had myself, a critical care nurse, and we'll call it the respiratory therapist. In the Air Force, they call it something a little bit different. And I think respiratory therapy is kind of a misnomer, right? They think of themselves as solely the experts of the ventilator or the breathing system, but really they're cardiopulmonary or critical illness technicians, right? So they should really, and hopefully this conversation empowers our respiratory therapists to really turn their heads when they see somebody that looks sick, right, and start to intervene. And unlike our AVM general patient, where we slap on a little bit of face mask oxygen, start to address some of the ventilatory deficits that these patients have, right? I can remember my respiratory therapist, for lack of a better term, walking up to get something to drink while we were en route across the pond, and our critically ill patients were in the back of the plane. The forward of the plane had post-surgical patients and other types of air evac patients that were being transported as well, but they weren't directly in our care. And I remember distinctly watching him do kind of a quick head nod and turn towards a patient that was clearly getting sicker. And it was a patient that had an amputation, who probably had gone septic. And so he kind of directed our team. We took care of that patient. And lo and behold, that patient was becoming shocky. So he knew that it was his place to intervene in that critically ill patient. And so hopefully, again, this conversation really empowers our therapists out there to expand their thoughts and to start to think of high velocity therapy in treating some of the ventilatory issues in these really sick patients. Okay, so we'll move to the next question. So from a practical application standpoint, what type of flow rates do you use on patients with increased work of breathing? And how do you manage the titration, like the oxygen and the flow titrations for these type patients that are not your typical lung pathology patients? And Dr. Samat, we'll start with you.
Yeah, I don't have one flow rate that I use on everybody. It's really every patient is different. I typically do start with the higher flow rate, 30 to 40 to start out, and 100% FiO2, and then I wean down the FiO2 really fast per their oxygen saturation and their tolerance. If they're tolerating 30, 40 liters per minute, totally fine. I'll keep them on that and follow up with blood gas. But otherwise, I could titrate it down. Typically for the COVID patients, we were using 20, even 20 liters per minute was just fine. That was more of an FiO2 issue, but every patient I would say is different, and we titrate it per their patient comfort level.
Oh, Dr. Greenberg.
Has everybody heard of the LLS sign? So the LLS sign is the best scoring system that's available on MD Calc. It's the looks like shit sign, and it's either yes or no. So if the patient's got a positive LLS sign, I put them on 40 liters a minute, 100%, no questions asked, and that's while all the other things are going on. If they don't quite have that positive LLS sign, but there's still increased work of breathing, then I'm probably starting between 25 and 30 liters a minute, and I'm doing my best to titrate that FiO2 to what they need. We know that a little bit of oxygen can be good. A lot of oxygen can also be bad. So I'm trying to be really careful to make certain that as I'm offloading that work of breathing, I'm being really, really careful not to provide any degree of biologic trauma to the lungs in the form of hyperoxia.
So Dr. Gephardt, I think we're pretty familiar with the LLS sign in emergency medicine.
Yes.
How long do you wait to determine if the therapy is effective in treating your patient, if they're going to do well on their patient on this therapy?
Dr. Hinckley, I'm pretty quick to go ahead and bring high velocity therapy to the bedside. So, it's that initial look, and I'm summoning respiratory therapy to the bedside, and we actually keep a unit in my department to get that to the bedside. So from an application standpoint, we're less than 10 minutes to actually go ahead and utilize high velocity therapy. The case I mentioned earlier, where I would have like an AFib RVR patient, I'm starting the patient around 30 liters per minute at about 40% while they're going, and then the LLS sign patient at about 100% and 40 liters per minute. And I typically am going to let that patient ride for 20, 30, 40, 45 minutes and watch what goes on, because there seems to be that magical moment somewhere between about 30 and 45 minutes where you see quite the improvement in work of breathing. And I mentioned that to the RT and to the RN who are at that bedside. Be observant, reassess your patient, and look at what's going on Q15 minutes. And they get to that 30 to 45 minute mark. They see that improvement in the work of breathing, and they have the epiphany, and they understand it, they get it. And then I sit down and explain more after the patient's up to the ICU or onto the medical unit about what they saw in front of them. So my answer to you is about 30 to 45 minutes is where I wait.
And Dr. Greenberg, is there any evidence that talks about determining when this therapy is effective or when it might be time to do something else?
There's the ICU ROC score, which is basically just looking at the respiratory rate and the oxygen saturation. But I really think that this pales in comparison to just sitting there looking and having a conversation with them. If I put the patient on, and I think it takes a couple minutes. And one of the things that I really try and emphasize anytime a patient goes on is let's see if we can make the exhalation longer than the inhalation. We know that that's where the expiratory flush is occurring. Let's see if I can maximize that time. The device goes on, I'm holding their hand, I'm talking them through it, I'm trying to engage that relaxation response. And almost inevitably by 10 minutes, you're seeing some degree of improvement. Now, by 2 hours, there's nothing hard and fast about that. I think that's when the ICU ROC score gets calculated. That's usually where are things moving in the right direction, yes or no?
And I would say that we know that in serious respiratory illness, specifically COPD, there was a paper out of Argentina that was done using entirely high velocity therapy that used 1 hour as their endpoint. And one of the things that paper was predictive of is if the patients are going to do well in the first hour, they're probably going to continue to do well. But if they don't, it might be time to look for something else. And I think, in the emergency departments and probably in the ICUs, this is what you guys are probably seeing. I don't know, Dr. Cement, any comments on that?
Yeah, I think you're referring to that Plotnikow trial, and that really needs to be taught to the respiratory therapy too, because we don't think about it in the high CO2 patients to use high velocity therapy, but the 1 hour is a great way to look at the patient. And it's such an easy thing because respiratory therapy here it's great. They see the patient and they do follow up. So now looking at the respiratory rate at time 1, and then in 1 hour, if your respiratory rate went from 30 to 22, hey, this patient's doing well. If the CO2 on your blood gas was 56 and you repeat it now and it's 50, we're doing the right thing. And the pH went from 7.32 to 7.37, boom. And there is going to be a failure rate of about 15%, which matches the failure rate on BiPAP or things like that. But at least you'll be able to monitor and know who's going to be successful. I think that's a beautiful new application that high velocity should target.
All right, we're going to go one more time around the room before we close this up. And so I'll ask you guys, any final tips on the application of therapy for increased work of breathing, or any of your thoughts on early intervention in these patients? And we'll start with Mark and we'll end with Jeremy. So go ahead, Dr. Gebhardt.
Absolutely early intervention. And for those who do emergency medicine, when you have an opportunity to know that this potential patient is coming in, like when you're alerted pre-hospital, my advice would be to go ahead and take those initial steps, make that call to respiratory therapy, and be thinking early about this. And I do this for our patients. I think my colleagues would agree that the earlier we can apply high velocity therapy in emergency medicine, the less downrange complications that are going to occur for our patients, and the easier the management is for those who provide inpatient medical care, be it in the ICU or in a step down sort of area. So get your respiratory therapist thinking early, sort of prime your nurses that this might be a way we go. And we in our clinical worlds deal with trauma alerts, cardiac alerts, stroke alerts. In my mind, this is almost a respiratory alert, so that we are getting our team of individuals thinking this way, that we're going to do something, not just a nasal cannula and not just a non-rebreather mask.
Dr. Cement?
My takeaway message from this hour is early. Number 2, follow-up parameters 1 hour. And number 3, don't hyperfixate just on oxygen saturation when looking for work of breathing.
And Dr. Greenberg, we'll give you the last word.
So resuscitating critical illness is a team sport, and everybody needs to be on board. When there's high work of breathing, you should apply high velocity therapy. RT should do this, nursing should do this, the medical students should do this, the residents, the attendants. It should be ubiquitous. It needs to be part of our initial resuscitation, not just on the ones with that positive LLS sign, not just on the ones where it's obvious and there's overt failure. It needs to be the go-to device for any and all patients with the potential of critical illness. Let's get all hands on deck and let's get that device going early.
Doctors, gentlemen, thank you all for joining us this morning, and have a good rest of your morning.